Wife of Mr. XYZ, 29-year-old dentist, resident of Sahiwal, married for 2 years, para 0 plus 0, having LMP of 4th of January 2024.
अच्छा ये मैं अभी
जी,
थोड़ा सा
जी,
मैं आपको यहाँ पे कर दूं
जी,
ये जो केस सिनेरियो है ये जो भी है इसका एक स्टैंडर्ड फॉर्मेट बनाइए आप ये दो फिक्रों में ये सारी इंफॉर्मेशन दे देना दैट्स नॉट फेयर या इस तरह से ये काफी वो दिस इज टू मच ऑफ इंफॉर्मेशन ऑन वन स्लाइड
right, sir.
तो इसका एक स्टैंडर्ड एंड एवरीवन व्हाइल प्रेजेंटिंग केस विल डू दैट आज मेरे साथ 15 मिनट लगाना तुम लोग बाद में
जी, sir.
चलो
With LMP of 4th January 2024, presented to the outpatient department with complaint of unable to conceive till now. History of presenting illness. This is the first and non-consanguineous marriage of the couple living together from past 3 months. Husband works abroad in Dubai. The couple initially lived together for 5 months of marriage. Then husband went abroad, visited her every 2 to 3 months for 2 weeks. History of regular unprotected coitus with coital frequency of 2 to 3 per week.
अब एक मिनट ठहरो इसकी हिस्ट्री में मुझे थोड़ा सा मसला नजर आ रहा है
जी सर
अब 3 महीने से अब रह रहे हैं
जी
5 महीने पहले रहे
जी सर
8 महीने हो
जी
गए
सर
हाउ मेनी टाइम्स डिड शी गो टू लिव फॉर 2 to 3 months
Sir, husband visited her for 2 to 3 weeks, for 2 weeks after every 2 to 3 months in between. Initially,
two
they lived,
weeks.
yes, sir.
Achha.
Initially, they lived together for 5 months.
Okay
Ji.
then husband went abroad and
Yes, sir.
visited her every 2 to 3 months for 2 weeks
Yes, sir. And from past 3 months, they are living together with having a regular unprotected coitus with coital frequency of 2 to 3 per week. According to patient, her husband is 32-year-old, having normal height and build, works in Dubai as a finance manager. No history of any medical illness, hypertension or diabetes mellitus, etc. No previous surgical history of...
etc card
Okay, sir. जी, sir.
etc नहीं लगाना etc लगाने का मतलब होता है you are trying to convey the impression that you know more than what actually you know
Right, sir. Right, sir. No previous surgical history of pelvic, inguinal or testicular region. Non-smoker, non-addict, no history of drug intake in the form of any antipsychotic or antidepressants. No history of radiotherapy or history of mumps in childhood. Also no history of recurrent UTI. Okay, as far as the menstrual history of the patient is concerned, she is having regular menstrual cycle of 5 by 30 days with average flow, soaks 2 to 3 pads per day. Having no history of dysmenorrhea, no complaint of postcoital bleeding or intermenstrual bleeding. No history of dyspareunia, no history of any pelvic intervention done before. Sir, here I'm referring to dye handling, which is usually very common in our society. No history of TB contact, no previous amenorrhea spell. There's no history of weight gain in the last 1 year, no history of acne, excessive hair growth on face. No history of hot flushes, night sweats, heat or cold intolerance, long-standing cough, evening rise of temperature. No history of headache, blurring of vision, palpitations, or discharge from her nipples. No history of pain in the lower abdomen or abnormal vaginal discharge or feeling of mass in the lower abdomen. Treatment history. She took ovulation induction 3 times, took last one in her previous cycle. There is no history of any tubal patency test done before in the form of HSG or diagnostic laparoscopy. Her pap smear was never taken and she never practiced any contraception. Medical history. There's no history of diabetes mellitus, hypertension, renal disease, cardiac disease, asthma or TB, or no history of any of these diseases in her family. Having no past surgical history. She's a non-smoker, non-addict, having normal sleep pattern, normal appetite, bladder and bowel habits were also normal. Not allergic to any drug. She belongs to a middle-class family, lives in her house of her own. Basic necessities of life are met with ease. Examination. A young lady sitting comfortably on the couch, well-oriented in time, place and person, answering my questions carefully with a BMI of 21.4 kg per meter square. Her vitals are pulse 82 per minute, blood pressure 110 by 80 millimeter of mercury, respiratory rate normal, afebrile. There is no pallor, no signs of koilonychia, jaundice, clubbing, or cyanosis present. All accessible lymph nodes are not enlarged. Thyroid is not enlarged. Both breasts are bilateral symmetrical with no lymph nodes palpable in any of the four quadrants. With having normal vesicular breathing in both lung fields with no added sounds and lung bases are clear. The apex beat palpable in the fifth intercostal space, left fifth intercostal space. First and second heart sounds were also audible with no added sounds. Abdominal examination. Slightly scaphoid abdomen moving with respiration and centrally placed umbilicus. No scar marks noted. On bimanual examination, uterus was anteverted, normal sized, mobile, no adnexal mass felt, by bilateral fornix is clear. Case summary. 29-year-old, married for 2 years, LMP of 4th of January 2024, husband age 32 years, with primary infertility, lived together for 8 months since marriage, took ovulation induction thrice, no history of dysmenorrhea or dyspareunia. On examination, abdominal and bimanual examination was unremarkable. Okay, sir. The investigations which I would like to carry in this patient would be baseline investigations and specific investigations. Baseline investigations include her complete blood picture, hepatitis B screening, C screening, HIV screening, and urine complete examination. Specific examinations will include, sir, her day 21 progesterone levels. Sir, progesterone levels are performed at day 21 when a patient is having a 28-day cycle, and in the patients having 30.
What is that?
सर इसका हमने नहीं कराया था, हमने सिर्फ TSH लेवल कराया था. मैंने वैसे बता दी है कि जनरल हम लोग क्या किस तरह प्रोसीड कर सकते हैं. तो if a
Why
patient,
do you have progesterone levels?
sir, basically, sir, in the mid luteal phase, which occurs 7 days before the upcoming menstrual cycle, the progesterone levels are the highest, up to 30 nanomole per liter. So basically, we want to confirm ovulation. That's why it's performed. Okay. So if,
What are other methods of confirming ovulation?
sir, first of all, we can have an idea of if she's having a regular menstrual cycle. And secondly, serum day 21 serum progesterone level in a 28-day cycle, and day 28 serum progesterones if a patient is having a cycle of 35 days. Also, sir, serum LH and FSH levels can be done on day 2 of her menstrual cycles. Then, sir, we'll get basically, sir, in this patient, serum TSH levels were performed, which were also within the normal range, 1.2 milli international unit per liter. And sir, serum prolactin levels would be done, will get done if a patient complains of headache, blurring of vision, to look for
मैंने
prolactin.
सवाल क्या पूछा था?
जी sir.
सवाल मैंने क्या पूछा था?
So ovulation.
Tests of ovulation. How do you determine? आपका जवाब number 1 दुरुस्त है. When you said that it is regular menstrual cycle की history हो.
जी.
बाकी किसी चीज से मुझे इत्तेफाक नहीं है. आप प्रोलैक्टिन को ऐसे खाम दरमियान में ले आए. एक मिनट बैठ जाओ ना. अपनी ना बोले तो FSH LH का क्या ताल्लुक है ओवुलेशन के साथ? उसके लेवल करवाने का. FSH LH have got everything to do with ovulation. But what is the purpose of doing FSH LH level on cycle day 2? How would they tell you about ovulation? What is the commonest test that we do for ovulation? What do we do most commonly to determine whether she is ovulating or not? Not serum progesterone. I have not even once in my entire professional career have asked any woman to have her serum progesterone on day 21.
Sir, TVS trans.
TVS, simple.
TVS.
Now, for the last more than 35 years, transvaginal ultrasound probes are available and they are commonplace.
Yes, sir.
And that is a very good method of determining whether follicular development is there or not. There are two things, as a matter of fact. One is that when you do that, you also know the antral follicular count.
Yes.
Antral count that tells you about the ovarian morphology and also ovarian reserve to a great extent. And in a given cycle, when you do at an appropriate time, when you perform ultrasound, you can from that, by assessment of the follicular size, you can see the follicle developing and whether it's developing or not. And then if you continue to follow it up, you want to make sure that she has ovulated, then you would see that on day 15, 16 in a regular cycle of say 28 to 30 days, the follicle would have ruptured, and there are now features which suggest that there is evidence of a collapsed follicle with periovarian small amount of fluid, etc., which would indicate that there recently ovulation has taken place. So follicular tracking is something which is carried out by ultrasound, and that's a good, simple, straightforward means which is not reliant on a lab investigation, right? That is what you do yourself. So you know it that the follicle developed, and then on such and such day of the cycle, it attained a particular size. Okay.
Yes, sir.
So that is what, after having said, when you are asked about what it is, so first is history of regular menstrual cycle. Number two, then other symptoms. Then many women, they would have middle cycle pain, which is known as Mittelschmerz. That's a German word. Mid-cycle pain, although ovulation takes place sometimes on right, sometimes on left, not necessarily only on one side, but most of the women have that ovulation pain only on one side, and most of them they have on the left side, even if the ovulation is taking place on right side. But anyway, that is it. The ovulation pain, and some may have even mid-cycle spotting. And previously, it used to be the change in the nature and characteristic of the cervical mucus. Initially, if you collected cervical mucus and spread it over a slide and saw under the microscope, you would see a ferning pattern, arborization. That was what it was called. And in later half of the cycle, in so-called luteal phase, or what is that? The one is follicular and the other is luteal. So in the luteal phase, if you did that, there would be absence of that. So that characteristic of cervical mucus, and then of course this ये सीरम प्रोजेस्टेरॉन जो तुमने कहा, तो अभी आप हिस्ट्री बोलोगे, हिस्ट्री में आप रेगुलर मेंस्ट्रुअल साइकिल, और उसके बाद दूसरी चीज जो आपने वो है एसोसिएटेड सिम्टम्स, और फिर आप बोलोगे फॉलिकुलर ट्रैकिंग बाय ट्रांसवेजाइनल अल्ट्रासाउंड, और फिर अगर थर्ड, मैं छठे सातवें नंबर पे रखूंगा, चाहे दरमियान में खाली कर दूं नंबर वो, तो फिर आप सीरम प्रोजेस्टेरॉन की बात करो.
Okay. Her husband's semen analysis was performed, which was within the normal range in this patient.
Yeah, it's normal in this patient. कहने के बजाय आप कहोगे कि the parameters, various parameters were within
the
normal
range,
limits.
right, sir. TVS, sir, as we
क्योंकि उसके बाद एक सवाल होगा कि what are those? What are the parameters?
Sir,
वो उसकी बात में करेंगे बात.
Okay, sir. As sir we discussed previously, TVS for follicular tracking, and sir.
क्या management बता रहे हो आप?
सर investigations है ना?
अच्छा.
Investigations है. पहले blood test हमने specific कर लिए, फिर semen analysis हो गया, then ultrasound, and then sir tubal patency tests. Okay, sir. Tubal patency tests can be done by 3 methods. Hysterocsalpingography, in which a dye is basically this is a simple, cheap, and relatively safe procedure with having 60% sensitivity, in which a radioactive dye is
radioactive,
radiopaque, sorry. A radiopaque dye is instilled through the cervix, and its flow is detected by.
Is it a water soluble dye or it's a fat soluble dye?
Water soluble.
Sir, water soluble is preferable nowadays.
Water soluble वो वही करनी. मैं तुम लोगों से पूछा, तुम लोग करते नहीं हो hysterossalpingogram. Otherwise the registrar used to take a histro tray to the radiology department, और वहां जाके जो gynae registrar है, they used to do it. वो इंजेक्ट करते थे और फिर वो जाहिर वो रेडियोग्राफर जो है वो फिल्म बनाता था.
Right, sir. So in this, a radio opaque dye is instilled through the cervix, cervical canal to see its flow through the cervical canal, uterine
Not
cavity,
see its
and
flow, वो हो जाता है,
जी
then you
sir.
take its image. From
Images,
the
yes,
image you
abdominal X-rays are
ये जो
taken.
because
Yes,
you are
sir.
confusing with hysterosalpingo contrast sonography, उसमें आप flow देखते हो,
Okay, sir.
क्योंकि जब इंजेक्ट किया जाता है
जी जी.
उसमें, तो वो then you normal saline उसमें इंजेक्ट करो, तो वो उस वक्त real time you can see the flow of
Flow.
the
Okay, sir.
fluid going into the
Okay, sir.
uterine cavity and through the tubes and out the through the fibrillats.
Okay,
वो
sir.
hypoxia जो है उसमें आप
Okay,
कर
sir.
सकते हो.
जी, देखिए sir. And another investigation which is being added is hysterosalpingo contrast sonography, in which the ultrasound technique is used to see the flow of dye through the uterine cavity and
उसमें कौन सी डाई डालते हैं?
sir इसमें भी यही
कौन सी?
uh,
Why would you वो instill this dye of which is radio opaque? Do you need radio opaque dye for that?
सर saline से कर saline से yes sir sorry saline से करेंगे और sir and sir hysterosalpingography is basically the primary test which is offered to the patient, but sir the gold standard is the laparoscopy and the dye test because sir it's sir, diagnostic laparoscopy and hysteroscopy was performed in this patient, which showed, sir, there's a writing mistake. It basically on hysteroscopy, both ostia seemed blocked. It's a writing mistake, sorry. Both ostia seemed blocked. On laparoscopy, no uterine or adnexal pathology was visible, but the dye test showed bilateral no dye fill or spill.
Did not show any spill
Spill
on
or-
either side. Bilateral.
Yes,
क्या-
Right, sir. So
ये-
impression of bilateral
चल.
block tube was made. Counseling. Okay. Sir, as we know, the subfertility is a problem which affects the couple. So counseling should be done of both partners, male and female. So we'll counsel the couple that they are having primary subfertility due to bilateral tubal blockage, and we'll explain them the findings of the test and give them treatment options which are available, taking into account their preferences and expectations. Depending upon the extent of tubal damage, option of recanalization, tubal surgery, or IVF can be given to the patient. Okay, tubal surgery. Sir, tubal surgery, a successful tubal surgery basically requires
ये
surgery.
कहाँ से पढ़ा तुमने?
Sir, EBM, EBM.
कौन ट्यूबल सर्जरी? एक इंग्लैंड में लंदन में हैमरस्मिथ हॉस्पिटल है, बड़ा मशहूर है.
जी.
वहां पे वो one of the great proponents of tubal surgery was Sir Winston. And he was master of that and उस वक्त वो था, लेकिन mid 80s late 80s में आके उसने भी छोड़ दी थी ट्यूबल सर्जरी करनी. क्यों?
Sir, first of all, sir, it
इसलिए कि
depends.
IVF के सक्सेस रेट
बेस
काफी
ज्यादा
अच्छा
जी
होता है,
ज्यादा अच्छा था प्लस और
इसलिए अब ट्यूबल
it's
सर्जरी
success-
का
जी सर बेसिकली
ट्यूबल सर्जरी का जो है वो स्कोप लिमिटेड है, वो जरा
जी.
वो भी बता दें.
जी जी बिल्कुल सर. The success rate of tubal surgery basically depends upon the underlying disease. It's more successful with mild tubal disease. At site of damage, proximal, distal, and the patient's age. Results.
What kind of tubal issue or problem is amenable to surgery?
Sir, proximal distal, proximal tubal blockage have better results.
उसके किस तरह से होगा?
Sir,
क्या? हाँ?
hysteroscopic canalization, laparoscopic guided can be.
यहाँ पे करना शुरू कर दिया ना कुछ लोगों ने करके, तो
अच्छा.
उसकी सक्सेस रेट देखी है कोई?
सर मुझे इस तरह से मिला नहीं, उसमें मैंने जहां देखा तो वही आ रहा था कि डिपेंड्स
ठीक है.
अपॉन दैट.
तो ये वाली बातें कैनलाइजेशन, ब्लॉक
सर.
ट्यूब का कोई इलाज नहीं है.
ठीक सर. ठीक
ट्यूबल सर्जरी का अगर कोई थोड़ा बहुत है, वो ट्यूबल सर्जरी नहीं है, दैट्स सर्जरी फॉर द रिप्रोडक्टिव ट्रैक्ट.
सर.
If there are adherents outside the tube, not blocked tube can't be opened.
ओके सर.
If the tube is blocked, it is blocked.
ओके सर.
You cannot excise a small segment of the tube or reimplant it. You can't do that like that if it's blocked. Sometimes even the tube is patent, but still it is non-functional. If it has been, if there has been chronic inflammation, like some cases of tuberculosis, or many cases of tuberculosis, as a matter of fact, or genital tuberculosis, in those the tubes are patent,
Right, sir.
but they are functionally not okay. The reason is that the tubal mucosa has been damaged
Damaged,
because
yeah.
of the
Inflammation.
inflammatory process, and so there is no ciliary effect. So
Right,
you
sir.
can't just take, say, plastic tubes and insert them in and implant them, and they would transport the ova. It's
Right,
not.
sir. Right, sir.
Ovum does not move like an amoeba,
Right, sir.
that it would move and move on its own. It is propelled by the cilia of the
Of the
tubal mucosa, tubal epithelium. So that is what is required. If that has been destroyed by inflammatory process, then no surgery would
Right,
help
sir.
that.
Right, sir.
And those tubes which are blocked, which have become thickened because of the inflammatory process again, and they can't be corrected.
Right,
The
sir.
only surgical option for tubal patency or for tubal disease is if there are adhesions outside
Right, sir.
which are disturbing tubo-ovarian relationship, so that the tube is kind of distorted and is
Anatomy distorted.
yes, there is distortion of anatomy, and there is no proximation of or possibility of proximation of, because it is chemotaxis that takes place when the ephemeral end of the tube is brought closer to the
Ovary.
ovary from where the ovulation is taking place, and therefore that helps it pick the egg from the ovary, the ephemeral ends. So if the ephemeral ends are blocked, you can't really tease them open and say you've done it, because they're damaged, right? And similarly, passing through or canalization of the tubes, I am very skeptical. Some would, until and unless I have seen it myself, that yes, there is a pregnancy because of that, despite tubal lumen damage. So I would be very
It can
skeptical.
also, sir, increase the chances of ectopic pregnancy as the tubes are damaged.
वो जो है, because if there is patchy damage of the tubal mucosa,
जी, sir.
that can give rise to that ectopic pregnancy.
Right.
But anyway, तो वो है कि अगर there are peritubal, periovarian adherence, but the tubes are patent, in those cases you would resort to surgery, or improvement
Right, sir.
after surgery
Right, sir.
can be expected.
Right, sir. Okay. Okay, so we'll skip this part. Okay. Sir, sir, the decision of IVF basically depends upon the patient's age and affordability of the couple. The optimal female age for IVF treatment in vitro fertilization is 29 to 30 years of the female partner. But sir, it should be explained to the couple that in vitro fertilization has a success rate of 40%. This should be practiced as such expensive procedure should be explained.
But
It's a common
that is
question.
the only option.
Yes, sir. It's a common question that like they say कि
ये आपने
yes,
थोड़ा
sir.
सा ना
जी, sir.
इसको कन्वर्ट कर दिया अपनी प्रेजेंटेशन. केस प्रेजेंटेशन इज आप हिस्ट्री बताओगे, आपने सारी उसमें साथ में जो थ्योरी है उसकी वो भी साथ में डाल दी, ऐसे नहीं करो.
अच्छा सर.
आप केस का एक हिस्ट्री बताओ,
जी सर.
ये पेशेंट है, उसकी क्या इन्वेस्टिगेशन है, क्या
अच्छा.
किया, और क्या उस पर्टिकुलर केस के लिए क्या इम्पोर्टेंट है, क्या आप करोगे.
जी.
सो उस तरीके से चलना
अच्छा,
चाहिए.
अच्छा.
यहाँ पे हमें पता नहीं चलता कि कहाँ पे क्या हुआ,
हाँ.
मैं तो भूल ही गया हूँ कि क्या था.
अच्छा.
Except that of course, और वो भी आपने उसमें गड़बड़ कर दी थी लिखने में,
जी.
that this patient had laparoscopy and hysteroscopy, and on hysteroscopy it was found that the
Ostia seemed blocked.
tubal ostia, they appeared to be blocked.
जी, sir.
They looked blocked.
जी, they seem to be blocked. जी.
But that is not the final thing until and unless you pass dye and you can't really see it going through. Only then you will know, and that's done on laparoscopy.
Right, sir.
At the time of laparoscopy, at that time you pass in the dye and you see it passing through. So laparoscopy is, what are the pros and cons of laparoscopy and hysterosalpingography?
Sir, hysterosalpingography, sir, sir, basically it can, it's a little risky procedure. Sir, it is cost effective. It is a simple procedure, but sir, at the same time, it should be avoided in the patient having previous history of pelvic inflammatory disease, tuberculosis, endometriosis, patient having suspicion of adhesions, because sir, it can flare up already existing pelvic inflammatory disease. So in such patient who are high risk, diagnostic laparoscopy should be preferred. And sir,
तो
diagnostic,
diagnostic laparoscopy
but sir,
उसमें नहीं वो flare up होगा.
sir, it is sir, relatively septic procedure in comparison to the hysterosalpingography. But
Septic कैसे?
sir, it's a sir, we take proper aseptic measures to perform it. But sir, it's actually a little expensive. There are
आप किसकी बात कर रहे हो?
diagnostic laparoscopy. It's little expensive as compared to hysterosalpingography. And sir, there are
होती है तो वार्ड में तो कोई एक्सपेंसिव नहीं होती. वार्ड में तो है आपकी. अगर पब्लिक सेक्टर हॉस्पिटल की बात कर रहे हैं वहां पे तो होती है तो वहां पे क्या एक्सपेंस आता है?
but sir, anesthesia, GA, general anesthesia fitness should be necessary for such patients.
तो फिटनेस वो तो यंग लड़कियां होती हैं तो उसमें तो फिटनेस वाली तो बात नहीं होगी कोई.
ठीक सर.
एनेस्थीसिया फिटनेस की बात नहीं करोगे. आप करोगे तो आप एडेड एक चीज होती है कि एनेस्थीसिया एनेस्थेटिक कॉम्प्लिकेशन ऑफ कोर्स हो सकती है. एनेस्थीसिया की कॉम्प्लिकेशन है. तो अब हम थोड़ी सी हमारी डिस्कशन जो है वो हैफेजेड तरीके से चल रही है. लेकिन अब इसलिए आपने अगर इसकी समरी बतानी है इस पेशेंट की तो क्या है और किस तरह से आप मैनेज करेंगे. अगर आप वो कहा जाए कि आप 5 या 6 लाइंस में इसकी समरी बताओ तो वो क्या होगी?
Yes sir, 29-year-old, married for 2 years, LMP 4th of January.
LMP नहीं, उसके बाद बताओ ना इकट्ठा कितना रहते हैं.
Yes sir, husband is 32
They
years.
have lived together sporadically.
Okay sir. Okay.
Married for 2 years,
2
but
years.
since husband is working abroad, they have in continuity they have lived for 8 months, 3 months one segment and 5 months one segment.
Yes, sir.
Otherwise, they have lived sporadically together
Right,
with
sir.
history of regular intercourse during the time that they were together.
Right, sir.
Mm.
Right,
Or-
sir. A history of ovulation induction thrice. No history of dysmenorrhea or dyspareunia. On examination, her abdominal and bimanual examination were unremarked.
नहीं वो तो
Okay, sir.
समरी में इस तरह की
अच्छा
डिटेल
जी,
नहीं
अच्छा
बताते.
जी.
समरी में आपने ये बताना है कि 29 years old,
Old.
married for 2 years, lived sporadically.
Sporadically,
Husband semen analysis is
normal,
normal.
normal,
Her menstrual cycle is normal,
normal.
and she has had hysteroscopy and laparoscopy. On hysteroscopy, ostia appeared to be
Is
blocked,
blocked.
and that was confirmed on laparoscopy when no spill of dye was seen coming from either side,
Right, sir.
and the tubes. Otherwise, there were no adherence.
Yes.
So the provisional diagnosis of tubal blockage was made,
Blockage was
and
made.
the couple was concerned about the treatment, which in such cases is
In vitro
IVF.
fertilization.
IVF.
Hmm.
वो है इस तरीके
Right,
से.
sir. Right,
So
sir.
that is actually the summary. आप उसमें आप हर चीज जो है उसकी अलग अलग से चीजें ले लोगे. जो क्वेश्चंस इसके लिए बनते हैं जिसके बारे में आपको मालूम होना चाहिए वो ये है. ये आप लड़कियां लिख भी लो अगर. What is the incidence of infertility in general population?
Mhm.
What is the incidence quoted यहाँ के लिए अगर आप करोगे? What is the incidence of infertility quoted in textbooks?
Mhm.
What is the incidence of infertility quoted for Pakistani population in local literature? जहाँ पे भी कहीं पे है. What is the distribution of what are types of जैसे female male factor infertility है? How does it epidemiologically? How does infertility factors found in husband and wife? What are the factors which contribute to male infertility? The major factors responsible for female infertility. ये theoretical चीजें हैं जो ये background आपको उस लिहाज से पता होनी चाहिए. अगर अब जब when you are looking at the history of a woman or a couple, actually it's a couple, then you will look at the time period that they have been living together. how long have they been practicing trying to have a pregnancy, उनकी एज होगी और वो चीज हिस्ट्री में सारी उस तरह की चीज होगी. उसके बाद वर्कअप जो आएगा, वर्कअप ऑफ इनफर्टिलिटी में फर्स्ट कोर्स अ डिटेल्ड हिस्ट्री ऑफ आइदर पार्टनर, कोइटल हिस्ट्री, मेंस्ट्रुअल हिस्ट्री और बाकी वो डिटेल्ड हिस्ट्री होगी. देन वर्कअप. वर्कअप में मैंने वो नहीं देखा, आपके बेसलाइन इन्वेस्टिगेशन करवाई थी आपने?
जी सर, तो मैं
वो करवा ली थी,
जी उससे स्टार्ट किया था.
बेसलाइन इन्वेस्टिगेशन होनी
जी
चाहिए.
जी बिल्कुल.
और उसमें आपने वो सही कहा था जब हस्बैंड की हिस्ट्री ले रहे थे कि उसने कोई एंटीसाइकोटिक ड्रग्स और दूसरी ऐसी एनी ड्रग व्हिच वुड अफेक्ट द
स्पर्म क्वालिटी.
स्पर्म वैल्यूज. फिर जब इन्वेस्टिगेशंस आती हैं तो इन्वेस्टिगेशन में जनरली हस्बैंड सीमेन एनालिसिस शुड बी कैरिड आउट फर्स्ट,
राइट सर.
बिकॉज इट इज नॉन इन्वेसिव. और जब आप कॉस्ट की बात कर रहे हो तो कंपैरेटिवली लेस कॉस्टली. But remember that whenever we request semen analysis, we also should be we should realize and we should know the parameters which are set out by WHO. Most of the labs that we get reports from do not follow WHO criteria, and we as doctors and particularly specialists in the field, we should be aware of the normal range of the count of sperms, its motility, and motility in terms also of not only motile but progressive motility.
Progressive, rapid motion.
And the third parameter which is important is morphology. Strict criteria morphology, sperms, if there are more than 4% sperms are of normal morphology, apparently on microscopic examination, it is within normal parameters. So that should be known, and even up to 15 million per ml count is considered to be normal, although that is the lower limit, but that is considered to be. और मोटिलिटी जहां तक सवाल है उसमें 40% प्रोग्रेसिव मोटिलिटी हो तो वो that's normal. But most of the labs which carry out proper semen analysis, they would give motility in terms of excellent, moderate, poor, and then no motility. So there would be 4 gradients of motility. And also when you ask for semen analysis, do advise the husband that it should generally be taken with minimum 3 days interval of intercourse, which should not be less than 3 days and not more than 5 days.
Okay, sir.
So that would give a better. And then also remember that just one semen report, if it is abnormal, should not be
Considered as final.
relied upon, and should not be any decision should not be taken on that. And a repeat semen analysis with an interval of 2 to 3 months should be carried out, and only then appropriate measures may be taken. So if you start looking at the different parameters, वो ये infographic जो है TUD वाला भी मैंने तुम लोगों को बताया था, मेल इनफर्टिलिटी वाला, वो दिखा दो. तो उसमें जो इम्प्रूवमेंट के लिए है कि लाइफस्टाइल मॉडिफिकेशन है, ओबेसिटी है, स्मोकिंग है, ईटिंग हैबिट्स हैं, एटसेट्रा, वो उनका जनरल इफेक्ट होता है, वो सब में ही आ जाती है, सब में ही लगा देते हैं. And we need to be careful about what we prescribe for improvement in semen parameters. And generally, we should try not to be educated by the medical representatives of various companies, because they come around bringing in various products, the ingredients of which are not necessarily vetted by proper scientific studies. So giving I'm not against any of those, but giving L-carnitine and things like that, which may not have proven value, one should resist prescribing those. Although sometimes I also prescribe those. for want of something better.
Right, sir.
When the husband would insist that please give me something for this, I generally prescribe vitamin E because I think it is innocuous. It helps vitamin E and vitamin C. They generally have a beneficial effect. So, and they are water soluble vitamins, they wouldn't have any adverse effects. So vitamin E 200 milligrams once a day and vitamin C 500 milligrams. So if they will not do any good, they at least would not do any harm also. But at least they'll have some placebo effect in addition to whatever effect they may have pharmacologically, right?
Yes, sir.
But if there are serious issues, serious problems, if there are values are less or and just in cases of azoospermia, I personally refer my patients to azoospermia. The examination of the patient should be carried out, of course. If there is azoospermia, physical examination to determine whether the testes are descended or not. What is the testes size, volume? What is the impression? So normal size, they are shriveled up, or there is any discrepancy from the normal. That's one. And then FSH level should be determined, serum FSH level of the man, because that also will tell you whether the azoospermia is because of hormonal issues or it is because of sometimes there is that bilateral blockage of the vas deferens. Professor Khaliqur Rahman here, he is a good surgeon. He does the microsurgery of the vas, and many a times I've seen that his interventions are quite useful. And to if this is really a common question by the couples, even if the values are normals, you see, if the value is say 15, 16 million count, they still would want to have it more, or they would say that something is still amiss. So in those cases, you start with the general counseling about lifestyle modifications, having healthy habits, exercise, etc. And then those, as I said, vitamins. And in addition, of course, the reassurance. And then in women, the major causes are, they are related to either ovulation or the tubal or the transport mechanism. Ovulation and transport, and anything which will affect that may be pelvic inflammatory disease, that may be even subclinical, not necessarily overt pelvic inflammatory disease. And issues like endometriosis, polycystic ovaries. So they can affect the tubal transportation of eggs and sperms, and on the other hand, problems of ovulation. And diseases like endometriosis, particularly, is common, and its incidence is high in infertile women. They have both effects. They interfere with ovulation. And endometriosis does interfere with ovulation as well as with the transport mechanism. And thirdly, by changing the chemical environment in the pelvis. It's a kind of a longish kind of debate or exchange of ideas about whether surgery for endometriosis, how far does that help, and when should that surgery be undertaken? I'll give you a presentation, or I'll sometimes talk about that. Endometriosis and infertility, we'll have that one session of that. Okay. No, in this particular case, if we just summarize again that in this particular case, semen analysis was normal. The couple was young, belonged to a young age, but there is a tubal issue, and that needs to be that the news ought to be broken to the couple in a kind of sensitive manner, saying that we have done this, that we have done that, and we've seen that the tubes appear to be affected by some issue and problem. And when it is, the tubes are blocked. And you can, as a matter of fact, when you are explaining to the couple, it's always handy to have a small, you can draw yourself a diagram of the uterus and the tubes, and you tell them that this is what is required. And you also draw the vaginal canal, and you can show that the sperms are here, the egg is here, and the egg has to move from ovary to the tube, and here the fertilization takes place because the sperms, if around that time intercourse takes place, and how long the egg is available for fertilization, and then the egg is propelled by the tubes towards the uterus, and then the uterine environment, because uterine hostility is also one of the factors that the endometrium should be good enough for that, for receptivity, so that it gets implanted there. So those are the factors that you explain, and then this here is the problem, and for this problem, this is the management, and this is the approach that you will do. So this is how you go about it. So this is an outline of infertility presentation and infertility management, but one can take up various portions of that. Say you can take up assisted reproductive techniques and when to do that, like intrauterine insemination ones, etc. Similarly, polycystic ovaries, a topic in itself. Male infertility would be a topic for discussion for one lecture in itself. So you can have multiple aspects of infertility. And as I said, endometriosis and infertility, that would be one. So we can have this. I have actually not my presentation, it's a Medscape presentation, but it's very good. Maybe next time we can have that, endometriosis and infertility. So it will be overall incidence of endometriosis and how it affects and all that, right?
Quite common problem.
Yeah. Any questions? We have on participants that
जी सर एक क्वेश्चन ये है कि इस पेशेंट के जो सिनेरियो है इसमें काउंसलिंग के टाइम हम उसको बता रहे हैं कि जो है पेशेंट को मतलब ब्रेकिंग बैड न्यूज कर ली हमने बताया कि ब्लॉक ट्यूब्स है जब वो हमसे रीजन पूछे इसकी हिस्ट्री में तो ऐसा कुछ रीजन नहीं है तो हम मतलब क्या कैसे बताएंगे कि क्या रीजन हो सकता है
रीजन उसकी ये है कि you see, and actually in most of these cases, as I said a little while ago, that there is a subclinical inflammation or infection. Hello, बस मैं 5 मिनट में. So subclinical infection which does not produce any symptoms related to the lower abdomen of pain, etc., or not overt pelvic inflammatory disease. For example, chlamydia infection, which is insidious, which causes comparatively common. It doesn't produce any symptoms, and it is there. We do not really know what is the incidence of tuberculosis here, but tuberculosis used to be an important part of pelvic inflammatory disease, and it is not primary tuberculosis of genital tract. It always came from other, or mostly, as the primary is usually in the lungs, intestine, or from the renal tract. So in most of the instances, genital tract is affected by tuberculosis secondarily. It is not the primary of them, but that is there. So a woman who has had treatment for tuberculosis, say for pulmonary tuberculosis, in that there would be likelihood of or she can be affected by that. But as we said, chlamydia is one, and subclinical infections and inflammations of genital tract. And Fiza did mention that she did not have any treatment or any exposure to dye treatment, which is again important that in our rural areas, still one would not be surprised to see that women, they have their treatments from Thai. Even educated people here in the cities, in city of Lahore, they come around and they talk about those notions and myths which were spread by guys or which we associate with the traditional birth attendants. So therefore, their role is also very much there. So one safe explanation for that would be that many a times there are inflammations and infections which are subclinical. Because the important point is, I think that maybe you wanted to make this point that we are not trying to convey to the woman that she has had infection so that her husband might consider that where did she get this infection from. So that is something that we have to take. We have to ward that off, that kind of impression, and therefore it is important to say that infection anywhere can spread and can go there, and it will be subclinical, not producing any symptoms, and therefore it can involve the tubes and cause the tubal blockage.
थैंक यू सर, इट वाज अ गुड एक्सप्लेनेशन। सर एक और चीज़ पूछनी थी एग्जाम पॉइंट ऑफ व्यू से, अगर यही पेशेंट हमें कहे मतलब शी इज़ वेरी यंग एंड मैरिड फॉर ओनली 2 इयर्स एंड लिविंग टुगेदर फॉर ओनली 8 मंथ्स कंटिन्यूअसली, सो ये जो है इजीली एक्सेप्ट नहीं करते आईवीएफ को डायरेक्टली, इवन कपल या फैमिली मेंबर्स, तो फैमिली, तो हम इनको जो है कैसे काउंसिल करें कि वो जो है आगे उसके लिए आईवीएफ के लिए या अडॉप्शन के लिए, क्योंकि हमारे पास तो 2 ऑप्शंस है ना, ट्यूबल सर्जरी इज अ माइक्रो सर्जरी और उसकी सक्सेस रेट भी इतनी कम है।
आपकी बात दुरुस्त है, आपने सही कहा कि a young couple who've been married only for say 2 years and straight away you tell them after having those investigation, you tell them that this is it, because generally it is considered that IVF would be the last option when others have all been exhausted. But unfortunately, in situations like that, one needs to explain that despite its cost, etc., but this is the option. This is the only option when the tubes are blocked. And a reference in the language that it's a kind of bypass operation. You see, if you have that diagram in front of you and you show that this is how normal conception takes place, but if you cross or put a cross on the tubes, so where would the egg, how would the sperms reach the egg, and how would a fertilized egg, if there was fertilization, or egg would reach the uterus? So if that passage is blocked, that is cut off, then how do you do? What do you do? Then you bring out the egg, mix it with the sperms, and then put it from below into the uterus. So that's how it is done. So you can say that in this situation, when the tube is blocked, we cannot repair the tube, we cannot canalize the tube, it would not be functional, and therefore it is essential. And it is better to, again, there is a factor of finances. A younger couple starting their life together, and within a couple of years' time, most of them, they will not have enough finances to afford IVF. But during that time, you can ask them to improve their general health and wait for the time that they can afford. But if the treatment is ultimately assisted reproductive technique, then that is the treatment.
Sir, what is the role of DHEA and POI, please, sir?
DHEA, dehydroepiandrosterone. I am not very convinced of this, but if you look at the pathway of how estrogen and progesterone are synthesized with the body, actually it is from cholesterol, it becomes pregnenolone, and pregnenolone to androgens, and from androgens to estrogens. So androgens actually form an important component of female hormones makeup. And DHEA is also one of them, dehydroepiandrosterone. So the purpose of providing DHEA or DHEA treatment as a treatment is to augment or increase the estrogen levels in a woman. So far as its purported role in improving the enteral count, I am rather skeptical about it. How would it do? Because it's if there is something which will be helped by increasing the levels of estrogens, that is okay. For example, in some cases, in young cases, we see that follicular development is good, but the endometrium doesn't correspond with that. There is no synchronous thickness or growth of the endometrium vis-a-vis the follicular development. On day 14, for example, we find that there are two follicles of about 18, 20 millimeter size, and the endometrium is 4.5 millimeter or 5 millimeter, because now it can be measured with such precision. In those cases, these days, for quite some time now, an estrogen preparation is started off in subsequent cycles. If one sees that persistently endometrium is rather thin, then you would start giving estrogens from day 5 onwards, so that the endometrium would also start to grow and would and that estrogen will not disturb the development of follicles as well. So one of the treatments that we give is Proganova, 1 tablet twice a day, starting from cycle day 5, to help the endometrium grow. On the other hand, you could also make a case for DHEA, because that is an intermediary, and if you provide that, that will be converted ultimately into estrogen, and that would be another source of estrogen. So that is one. Then DHEA has some role also for postmenopausal women also, in whom you do not want to give direct estrogen, or estrogen is not available. DHEA has some role in menopausal symptoms management. But apart from that, I am not sure how far it is going to affect the development of eggs, or how it is going to have any beneficial effect on the potential of the ovaries.
सर एक लास्ट क्वेश्चन सर, जो एंट्रल फॉलिकुलर काउंट होता है ओवेरियन रिजर्व के लिए, उसके लिए कोई पर्टिकुलर डेज है साइकिल के जिस पे हम चेक करें?
No, not necessarily, because particular days ultrasound is carried out only to see a growing follicle or its size. Antral count actually can be done on any day. A good vaginal probe will show the ovarian morphology quite eminently, quite nicely, and you can see the follicles. We do get a regular report of 7 to 8 antral follicles, 4 to 5 antral follicles, or 12 to 14, or 14 to 16. So that is something which is quite readily available, at least to us here, and therefore I think it's a comparatively simple matter. If you have an ultrasound machine, you're a practicing gynecologist, and you can a vaginal probe is not very expensive, and you have that, and if you just get the hang of doing a vaginal ultrasound, you can assess both the endometrial thickness. You need to have a little bit of training, and visualize the ovaries, and that will help your practice a lot, because you will be able to not only see the antral follicles, you will also be able to make a diagnosis of PCO with greater degree of certainty, because when you see too many follicles, and then if you are practicing ovarian stimulation, then you can also see what kind of effect your stimulation drugs are having on the ovaries, at the same time to prevent hyperstimulation. So it's quite useful to have a vaginal probe with your ultrasound machine. अगली दफा मैं पढ़ के आऊंगा इनफर्टिलिटी।
सॉरी, बहुत सारे क्रॉस क्वेश्चंस कर लिए।
नहीं बिल्कुल कोई नहीं, अगली दफा भी करना क्वेश्चन, आप जरूर करना।
इंशाल्लाह इंशाल्लाह। जब ये पता हो ना तो क्वेश्चन करने में भी मतलब वो जो है पता चलता है कि ये क्लियर हो गया।
हाँ नहीं नहीं जरूर करें, क्वेश्चन करने से ही पता चलेगा। ठीक।